Hey doc, I got a simple problem. You got something to help me sleep? Oh my goodness, those dreaded words. So innocent, so simple. Not really. Hello everyone, I'm Dr. Renee Kohansky and welcome to episode 10 of Clinical Correlation. Don't you sometimes wish we could just give one dose of IV Versed? Our poor blessed patients, don't they deserve at least that? One quiet, peaceful night of blissful sleep. People call thinking it's the easiest request. Really, just a little thing. And we all know it never ever is. Okay, everybody, how many insomnia seminars have we each attended? And we all know the insomnia gurus, right? We've been to their lectures at the big conferences, and we know the meds. Do we? Well, it's worth another look-see because, after all, this is the bane of our existence, with commentary and clinical correlation, of course, because, well, that's why we're here. Obviously, I can't do all of sleep disorder in a commentary because, well, no possible way I could do that justice. I'll leave that for the gurus and the N+1 formal insomnia lecture we will each attend. But some experiential pearls and the stuff our amazing patients teach us that is never in the books. In fact, for just these little tidbits, I need 2 programs. Consider this part 1. And incidentally, I'm not looking at the etiology or workup of insomnia. For example, a sleep study looking for apnea or narcolepsy, which are their own interesting topics. But however, I'll recommend that everyone be familiar with the Epworth Sleep Scale if you aren't already. Question: am I speaking of insomnia or lack of wakefulness for this program? This is kind of an existential than a pharmacologic question. To go one level deeper, am I speaking consciousness or altered consciousness? Maybe this is really an anesthesia lecture. Start asking these questions and we can begin to understand why sleep, sleeplessness, wakefulness can be such an elusive creature. Add loss of schedule, isolation, and this massive disruptor called SARS-2 coronavirus, and well, here we are, sports fans. No wonder there are so many systems involved. But we need to start somewhere, and rather than taking Julie Andrews' advice and starting at the very beginning, let's start at the very end with the Z drugs. Zolpidem, Zaleplone, S-Zopiclone, and we know these compounds are thought to act by interacting with GABA receptor complexes by binding domains allosterically coupled to benzodiazepine receptors, the so-called non-benzodiazepines, marketed as just as good as benzos but without all those nasty dependency problems. But of course, that wasn't really true. And without major side effects. Well, except for that little retrograde amnesia thingy. Yet, despite those shortcomings, we actually know there really is a place for these little fellers. And depending on whether we are dealing with initial, middle, or terminal insomnia, we can look at the half-lives of the medications and the immediate release versus long-acting formulation and decide where they belong in our little toolbox. Naturally, of course, it's recommended for short-term use only. But of course, that being said, there are those who seem to do just fine on some of these medications long-term, even, dare I say, years, because in psychiatry, no individual patient ever truly follows the rules, and we are always absolutely in a land of informed consent, quality of life, constant risk-benefit analysis. Never say never. So let's take the hypothetical where we believe we're helping our geriatric patient by denying her prescription of 2.5 milligrams of Zolpidem, where she's been taking this for the past 20 years. We conscientiously and with good heart discontinue it because we've read about cognitive impairments. We understand about the risk of falls, broken hips, etc. we hold her hand through the rebound insomnia that never, ever, ever goes away. She's miserable. And if we didn't have professional boundaries, we'd be miserable. But actually, we are miserable for her. So we wait X months. Fill in the value of X to your heart's content. Trust me, X can equal any value because there is some value of X for which she will not get better until you restore the Zolpidem. Tell me, Rabbit, will you resume the Zolpidem? I don't have an answer, just a question and my own clinical experience. Because patients don't read books, their brain chemistries don't always follow the books, and the bottom line is its clinical decisions. And as I've said, risk-benefit analysis, relationship with your patients, good note-taking, and the art of medicine. Now, I'm going to save our heavy hitters for part 2, the big boys of sleeps. You know them, you love them, or you hate them, and we have a lot to say about them. Yes, the benzodiazepines, the hypnotics, the anxiolytics, the so-called minor tranquilizers. And I actually can't wait to hear what you have to say as well. That's going to be fun. And nope, we are not even going to touch the barbiturates because let's face it, we don't use them anymore. I hope also to be able to say a word on the major tranquilizers as well, also known as the SGAs, second generation antipsychotics, or a million other names. Because again, this is clinical correlation and of course the land of off-label and informed consent. So now moving into some of the heterocyclic compounds. What is our most commonly used? Go to PRN sleep med. Quick, answer me without even thinking. The PRN you use that's not addictive, you think is pretty harmless. Go. What's the name of it? Trazodone, right? Especially if you're in any kind of inpatient setting or dual diagnosis. Any place where patients are not naive to the medication. You're all rolling your eyes because you know it's trazodone, right? And you know how to use it, right? You're saying, Dr. Kohansky, what are you talking about? Yes, I understand. You're experts. I really get it. I know you are. But here are some pearls. 1, trazodone may not be so harmless to everyone, but certainly good for particular populations. 2, my belief, and consequently your belief as well, goes a long way towards the effectiveness of a compound. But if, and only if, we truly believe, and I personally actually have come to become a believer of trazodone for the right patient. 3, dosing pearls. So again, I know a lot of you know this, but there are some like little tweaks that I've gotten on this. I have found the key, like everything else, particularly for the naive patient, I'm talking the naive patient, is low and slow. I know you know this, but wait, there's more. Where I was using it incorrectly was in thinking more is better, right? More equals more better. Someone's not sleeping, slam them with enough trazodone and you can knock them out, right? Wrong. You just make them feel like crud and they hate you. Having your patient hate you is not typically a good way to go. And that doesn't feel good. That strategy is not for the trazodone naive, at least actually not in my personal experience. And I want to hear from you because I know that there's enough out there listening that have different experiences, and I always want to hear about different people's clinical world. So let me know if you've had a different experience, and I'm talking about the trazodone naive patient. By this I mean you gave somebody 25 milligrams and it didn't work, and a naive person. So you rapidly titrated them to a very high dose, say 100 to 200 milligrams, and you found that it actually made them go to sleep, and here's the key part, without making them feel awful the next day. I have found that this is the right agent, but for the right person, but in order to make it work, this is where it was actually radically different for me. It had to be coaxed on slowly. So I had to give them the 25 milligrams, and they would say, Doc, the 25 milligrams didn't do anything. And I would have to say, because I really did come to believe in it, okay, this medication really does work. Stay with it. Stay with the 25 milligrams, and then we're going to increase you up to the 50 milligrams. And balancing those antihistaminic side effects with waiting and coming on slowly, gradually up to a dose of somewhere usually between 50 maybe 100 milligrams, so really somewhere between even 25, somewhere 25, 50, 75. Okay, now for the side effects. Remember, it's the antihistaminic properties that are sedating, so we have to be careful in folks for whom this is going to be problematic. Think elderly. Also, remember, it blocks alpha-1 receptors, so you must caution your patients about arising slowly or they can pass out. And, if they pass out on you, you're back to where your patients aren't particularly happy. Unhappy patients make for unhappy doctors. Okay, so now, thanks to Dr. Stephen Stahl for this next statistic and little factoid. The risk of priapism, I've always said it's pretty low, but I didn't actually have the number. He quotes the number at about 1 in 8,000. And a harbinger of impending priapism may be slow penile detumescence when awakening from REM sleep. So basically, for men, if they're waking up and they're waking up with an erection and they're having a difficult time with the erection going down when they're waking up, that could be a sign that they may be somebody who's at a risk for developing priapism. So if you're going to use trazodone in men, which you can do, or clinically, let me just say clinically, you may decide you want to do it, this might be a risk of somebody who's going to develop priapism if you decide you want to use trazodone for men. And with the risk of 1 in 8,000, you have to decide with your patient if that's a risk you want to take. A lot of people say, yes, that's a risk that we can take with our patient. Okay, and here's a factoid that I actually did not know, so thank you, Stephen Stahl, once again, because I didn't know it. I think it's kind of cool. I don't necessarily know that I would include this in my informed consent because there's a whole argument for too much information can actually impair informed consent. So you have to decide what's the amount of information that you can give your patient that's the necessary amount of information for providing informed consent. Certainly, I think antihistaminic properties and the mechanism of action and the risk of antihistaminic properties in elderly patients is part of informed consent, and absolutely the risk of getting hypotension is absolutely a part of informed consent. But this one is kind of interesting and just cool whether or not you want to include it. I do it in the right context. But anyway, here it is. Rarely, patients complain about visual trails or after images from trazodone. So I think that's more interesting in that if somebody tells me about it, it's not somebody making up something, because sometimes patients have unusual side effects and you think, what is that? Is that some kind of material that's psychologically mediated rather than pharmacologically mediated? So this one sounds like it's pharmacologically mediated. Okay, guys, that brings us to the end of, hey, doc, I just need a quick consult for about 5 minutes to help me get something to sleep, which is really more like a very extensive evaluation. And part 2 is going to be just as much fun as we continue this exploration, because you know what? We can never talk about this topic too much. I really look forward to your comments as well. I'm Dr. Renee Kohansky for Clinical Correlation.